so much for having us. I'm Megan Brockmeyer. I'm the Drug Overdose Prevention Research Coordinator in the Medical Examiner's Office.
Truman. And I'm Michael Staley. I'm the Suicide Prevention Research Coordinator at the Office of the Medical Examiner. And, I'm really glad that we had Sarah up and then that there's going to be a sound bath after we're talking, because no one invites us to a party to kick the mood up a little. So yeah, usually when we're walking from the car into the party, that's when my husband says, "You are an accountant tonight, and you are not allowed to talk about your job, dude." It would not be the first time that we've had to have, turn down the music and we need to gather in a circle and talk about people's experiences. We're going to talk about the most current data that we're able to present today related to suicide and overdose in our state, and talk about some unique ways that we're collecting data and ways that that data is being used to inform prevention, intervention, and postvention in our state. I wanted you guys know about 988. I know that. I'm preaching to the choir. But I want to say that no one is exempt from a crisis. Psychiatrists die by suicide. Psychiatrists die from drug overdoses. And so this number is for you too. But I also want to add that we think about, you need to call 988 when you're experiencing the darkest hour of your life. Or, we don't think, or we don't tell people who are drowning that they have to save themselves. You're going to have to climb on this boat, get this life ring, and then go back and save yourself. We really have to empower ourselves and those around us as bystanders. We're the ones that are going to help flip that switch on. Maybe, can I call 988 with you? Or, I've been doing mental health care or substance use treatment for 20 years, and this situation is unlike any I've ever experienced before. And I just am not 100% confident about my decision. I'm not sure what I should do. Call 988. These are folks that deal with crisis every hour of every single day, and they can help you navigate what the next step should be. I also want to acknowledge that we're going to talk about people who died very tragically in aggregate. But as you just heard from Sarah, these are people's stories that are the tragedies that define their families' outcomes, that define how they go forward in life. And that's not lost on us. We know that every single one of these deaths represents somebody's worst day and that time that their life changed forever. Then I'm going to begin by talking about trends in suicide mortality today. And I'm mostly going to be presenting on data that ends in 2023. That's the most current data year that you can get publicly. But I'm going to give you a little update beyond that as well. So the best characterization of what's going on in Utah is that suicide rates went up for a really long time. We have dates that go back to 2004 here, but it's a little bit deceptive. Because if you go back in this line a little bit further to the 90s, this line goes about the same, but a little bit lower. And what happened in the late 90s? We changed the way that we were coding suicides from ICD-9 to ICD-10. The 90s represent actually one of the lowest periods of suicide rates in the US since we've been tracking suicide rates. And so it always looks like, when we look at this figure, which you've probably seen in some contexts before, that suicide rates were low and then they really went up. But if you expand that timeline, it's actually more of this valley that's the 90s. So suicide rates went up in Utah between 2008 to about 2014, 2015. And I know that this might be kind of small from out there, so I'm going to try to tell you a little bit of what I'm talking about. The count is the purple line, and the rate, which is the adjustment for the population, as our population has grown, is this teal line right here. And so we kind of plateau around 2015, and we continue all the way through one of our lowest years, strangely, 2021, until we get to 2022. 2022, 2 years after the pandemic, is at least the public health restrictions part of it. The worst of it is over. And no surprise here, this is where we see the biggest increase in suicide death. It's also true of the Great Recession in 2008. It's true of the people impacted by September 11th attacks. It's true of all of these national or local events. It takes a while. And I think what we're seeing here is a story of people who didn't recover from the pandemic. It's one thing when Megan and I go to work, we're back in the office and our lives are going well, but we know that the pandemic some people didn't recover from the pandemic. This is just a zoom in on the last 7 years. The trend line is that teal line there. And you can see that 2022 and then this dip just a little bit. There is a lot of danger in saying that the suicide rate in Utah is stable. What do you think about when somebody comes out of the OR or the ED and they're stable? Everybody goes, thank goodness we made it through the worst of it. This is a 5-alarm fire. This is not normal. While it's stable, it's not going up. That's good. We wouldn't want it to continue to go up. But our goal was never to keep suicide rates the same. Our goal is zero suicide. And we're far from that goal here. We're still in the top 10 states, and we still have a lot of work to do despite all of the good work that you all and our partners are doing. So this figure adds in 2024. This is provisional data. The counts are still kind of going up and going down a little bit. This is count, by the way, not rate. 2024 is that purple piece down there at the end. So basically, not much changed in 2024. We're expecting, because of population growth, not necessarily change in the number of people who are dying, but because the population continues to grow, that the suicide rate will likely decrease just very modestly in 2024. Nationally, males account for about 3 suicides for every 1 female who dies by suicide. In Utah, it's more like 4 out of 5 people who die by suicide identified as male. And this is a disparity that continues to widen. When I started in this role in 2017, we looked a lot more like the national trends, but over time, this has continued to grow, meaning more males are dying by suicide. And a lot of those decreases that we've seen were driven usually by females. That not a lot of change with males, except for that it continues to increase in some years. This also shows sex as well, age and sex. How many of you think that if you were to talk about suicide, what's the group that you're told dies by suicide the most? Teens. That people think that teens die by suicide the most in our state. And that's, I don't blame them for thinking that. If you Google suicide in Utah, you're going to get a bunch of news articles about teen suicide. But teens actually represent about 5% of all people who die by suicide in our state. That's not to say that those tragedies are, any less. We don't measure tragedy, we measure counts. And so if you're talking to, say, Rio Tinto or a group of middle-aged working men, they're just shocked by these numbers. I'm like, you are the most likely person in Utah to die by suicide. The person sitting next to you is the most likely person to die by suicide. Over time, we've seen subtle decreases in the 0 to 17 age group and the 18 to 24-year-old age group. Now, we don't have the science that would causally link our prevention work to the decreases in these 2 age groups. But if you think about where as a state, where we locally invested the most in suicide prevention, it's been these 2 groups. I think correlation is good enough for me to say we're doing something that's working in these 2 age groups. So we need to invest the same amount of resources that we have in youth in these other age groups. Since the pandemic, those 2 age groups down there on the end have seen year over year increases in suicide. It used to be very strange, very odd for a woman over the age of 65 to die by suicide, and extremely rare. Like a 1 in 5 year event, the elderly woman would die by suicide using a firearm. And now, I'm not going to say that's an everyday kind of thing or even a very weak kind of thing. But surprise here, this is where we see the biggest increase in suicide death. It's also true of the Great Recession in 2008. It's true of the people impacted by September 11th attacks. It's true of all of these national or local events. It takes a while. And I think what we're seeing here is a story of people who didn't recover from the pandemic. It's one thing when Megan and I go to work, we're back in the office and our lives are going well, but we know that the pandemic some people didn't recover from the pandemic. This is just a zoom in on the last 7 years. The trend line is that teal line there. You can see that 2022 and then this dip just a little bit. There is a lot of danger in saying that the suicide rate in Utah is stable. What do you think about when somebody comes out of the OR or the ED and they're stable? Everybody goes, thank goodness we made it through the worst of it. This is a 5-alarm fire. This is not normal. While it's stable, it's not going up. That's good. We wouldn't want it to continue to go up. But our goal was never to keep suicide rates the same. Our goal is zero suicide, and we're far from that goal here. We're still in the top 10 states, and we still have a lot of work to do despite all of the good work that you all and our partners are doing. So this figure adds in 2024. This is provisional data. The counts are still kind of going up and going down a little bit. This is count, by the way, not rate. 2024 is that purple piece down there at the end. So basically, not much changed in 2024. We're expecting, because of population growth, not necessarily change in the number of people who are dying, but because the population continues to grow, that the suicide rate will likely decrease just very modestly in 2024. Nationally, males account for about 3 suicides for every 1 female who dies by suicide. In Utah, it's more like 4 out of 5 people who die by suicide identified as male. And this is a disparity that continues to widen. When I started in this role in 2017, we looked a lot more like the national trends, but over time, this has continued to grow, meaning more males are dying by suicide. And a lot of those decreases that we've seen were driven usually by females. Not a lot of change with males, except for that it continues to increase in some years. This also shows sex as well, age and sex. How many of you think that if you were to talk about suicide, what's the group that you're told dies by suicide the most? Teens. That people think that teens die by suicide the most in our state. And that's, I don't blame them for thinking that. If you Google suicide in Utah, you're going to get a bunch of news articles about teen suicide. But teens actually represent about 5% of all people who die by suicide in our state. That's not to say that those tragedies are, any less. We don't measure tragedy, we measure counts. And so if you're talking to, say, Rio Tinto or a group of middle-aged working men, they're just shocked by these numbers. I'm like, you are the most likely person in Utah to die by suicide. The person sitting next to you is the most likely person to die by suicide. Over time, we've seen subtle decreases in the 0 to 17 age group and the 18 to 24-year-old age group. Now, we don't have the science that would causally link our prevention work to the decreases in these 2 age groups. But if you think about where as a state, where we locally invested the most in suicide prevention, it's been these 2 groups. I think correlation is good enough for me to say we're doing something that's working in these 2 age groups. So we need to invest the same amount of resources that we have in youth in these other age groups. Since the pandemic, those two age groups down there on the end have seen year over year increases in suicide. It used to be very strange, very odd for a woman over the age of 65 to die by suicide, and extremely rare. Like a 1 in 5 year event, the elderly woman would die by suicide using a firearm. And now, I'm not going to say that's an everyday kind of thing or even a very weak kind of thing, but
So in Utah, the drug overdose death rate increases significantly, of course, between 2000, you really like 2006, and then it increases again up until about 2015. In 2015, we see the rates start to flatten, but we're really just staying at peak levels. So in 2023, as Michael mentioned, the most current full year of data, there were 606 overdose deaths in our state. This was the highest that we've ever seen.
toughtens.
So I think if I go back here, it's encouraging, of course, that our death rate has remained stable, if you will. However, the counts do continue to increase. So Utah is still one of 3 states to see an increase in overdose counts compared to the rest of the country. Our trends have looked a lot different than national trends have for quite some time, especially for the last 5 years. So if I showed you guys a graph of what was happening nationally, you would see these significant year-over-year increases that start around, of course, at the onset of the pandemic. In Utah, as you remember, things stayed really flat. Now, nationally, we're seeing decreases everywhere except for now in Utah, Nevada, and Alaska. I also included a graph here that shows the previous 60 months in Utah. And it actually looks really similar to the suicide graph. So we're seeing a pretty slight increase over this 5-year period. And then I included some more recent data in 2024. So a good link there. And so you can see from month to month, there's a lot of variability. But it doesn't look as of right now that we're going to see a significant decrease in our counts in 2024. So we're going to remain flat again, very, very likely. So here we're looking at the types of substances that are involved in overdoses in Utah. There's a lot of different stories here. So this information comes from the death certificate. When one of our pathologists will sign the death certificate, they will include the substances that caused their death. So this could be in combination with another drug, or the level was lethal enough for one drug to have caused the death. This does not mean that this was just simply in their system. So you can see we've invested a lot of resources in reducing the number of opioid prescriptions in our state, and that's really reflected well here in that line. So there's been a significant decrease in the number of deaths that involve at least one opioid prescription. Though, of course, we're still seeing deaths where there are opioid prescriptions. Another really prominent story that I'm sure all of you guys have heard about is the significant increase in the number of deaths that have involved fentanyl. It's the yellow line here. So in 2023, fentanyl surpassed methamphetamine for the first time and was the most commonly involved drug in overdoses, in overdose deaths, So that really starts to increase again at the onset of the pandemic. In 2020, first quarter of 2020, we see a huge increase in fentanyl deaths. And that's just continued on. In national trends, we see that the synthetic opioid kind of wave of the overdose crisis hits quite a bit earlier. And that's pretty common for Utah. It seems that some of these trends, as far as substances go, occur in Utah a little bit later than we see in national trends. Something that I don't think we talk quite as much about is meth. Meth is a significant public health threat in our state. It's been the most commonly involved drug in overdoses since 2017 until fentanyl in 2023. And if I were a betting person, I would bet that meth is going to be the most common drug again in 2024 in overdose deaths. So again, it's very prevalent, it's very widely used, and it's a significant problem in our state. Another interesting trend we've seen is this pretty significant reduction in the number of heroin deaths. So we really see that from 2022 to 2023. And then I included gabapentin because if I showed you a list of the most common substances involved in overdoses in 2023, you would see fentanyl, meth, gabapentin. So it's the most common prescription drug that we're seeing in overdoses, more common than oxycodone or morphine. So I included that there. And then cocaine has remained pretty stable over time. So we don't see big shifts in or changes in cocaine. I didn't include here what I wanted to mention, just the impact that alcohol also has. We see, so if I went back to that top 10 list of substances, the substance that would be behind gabapentin is actually alcohol. And because of the way we try to align our methodology with the Centers for Disease Control and Prevention, so we exclude alcohol-only deaths from this type of reporting. So if we added those in there, you would see ethanol or alcohol jump way up in the rankings. Alcohol is also a significant problem in our state.
Good.
I wanted to just talk briefly about some emerging drug threats. I get a lot of questions about, like, what are we seeing? Is this here? And so I wanted to include a little bit of information about that. So the first thing I have up here is nitazines, which are a synthetic opioid. And we've seen a big increase in nitazene deaths around the world. There are not a lot of deaths. There's actually been less than 6 deaths in our state that involved a nitazene, but they've all occurred within the last 12 to 15 months. And this is actually very similar for all of the drugs that are listed on this slide here. Parafluorofentanyl is an opioid analog. Again, it's not very common, but it's definitely become more prevalent in the last recent years. We've seen about 14 deaths involving parafluorofentanyl. And what's interesting about that is that there's actually not fentanyl in any of those deaths. So we're just seeing that analog. Carfentanil is very rare still in Utah. We've had less than 5 deaths involving carfentanil. Again, though, they've been more recent within the last 12 months. Carfentanil is also a fentanyl analog. Bromozolam is a synthetic benzo. And this has been a really interesting thing to see. So we had not seen any bromozolam in our state until 2021. And now there are about 20 deaths. And 75% of those deaths have occurred in 2024. I don't have any data on 2025 yet. So again, uncommon, but definitely here and occurring in the recent 12 to 15 month period. I included ketamine because there was a recent report from I think it was from the CDC, and they were seeing a bit of an increase in ketamine deaths around the country. I don't know if that surprises anybody, but I hadn't really heard of this. So I looked in Utah data. It's still uncommon. Less than 1% of our overdose deaths involve ketamine. But similar to the rest of these drugs, there's been a bit of a surge in ketamine-related deaths recently. And then lastly is mitragynine or kratom, which is, of course, pretty common. We see that a lot more than we ever have lately. So I want to say in 2020, there were about 20 deaths, and if we fast forward to 2024, there are about 35 deaths. So prior to that, of course, we weren't seeing any deaths involving kratom, or it was very, very rare. Now it's becoming much more common. And actually, in 2023, it made the top 10 list of the most common substances involved in overdoses. And then I also wanted to add a slide on stirring, difluoroethane, because this is something that we don't talk about. It's not included in my normal surveillance because it's not technically considered a drug, Though if I look at our non-drug poisoning, so this would include other things like carbon monoxide, we see that duster is the most common substance involved in overdoses that are not, is not a drug. Then just moving on, talking a little bit about some of the disparities that we're seeing in drug overdoses. Similar to suicides, we see that males ages 35 to 44 had the highest rate. The middle age groups are a little bit higher, well, actually quite a bit higher in overdose than they are in suicide. But you can see here that males are much more likely to die by an overdose than females. And again, similar to overdose, similar to suicide, it's rare to see deaths in children. So kiddos ages 0 to 17 accounted for less than 1% of all overdose deaths in 2023. I think the important thing to note here is that they had the highest proportion, of course counts are low, but they had the highest proportion of deaths that involved fentanyl. So in 2023, 8% of the deaths involved fentanyl among this age group. Another group of folks that are really disproportionately impacted by overdose are people who are experiencing homelessness. 29% of deaths among people experiencing homelessness were from drug overdoses, compared to 2.4% of those who were not homeless or the general population. And then just kind of diving in here a little bit to talk more about geography. The drug overdose death rate was the highest here in Southeast Health District in this 3-year period. So we don't see big differences between rural communities and urban communities in our state as far as fatal drug overdose rates go. Southeast, Tri-County, Weber, Morgan, and Salt Lake County have consistently had higher rates than other places across the state. All 4 of those areas have higher rates than the state rate. Then I just wanted to share a little bit of information specifically about Southeast. I'm not trying to pick on Southeast at all, but just wanted to share it since we're here. Southeast, of course, has been disproportionately impacted by fatal drug overdose. So unfortunately, the rates have been higher in Southeast ever since the onset of the overdose crisis. And that's just continued over time. So included in this graph here, the Southeast, which is the top line, the teal line, and then the state is the lower line. So you can see consistently over time, Southeast has had a much higher rate than the state rate. In Southeast, 3 out of 5 overdose deaths are among males. This is really similar to the state. So males, again, are at higher risk of dying by an overdose. And then similar to the state, same age group is really impacted here in Southeast. People ages 35 to 54 had the highest rate.
Well,
The state, if I were showing state data on this, you would see that about 70% of all overdoses in our state involve multiple substances. So kind of going back to the substance slide I was showing earlier. So that means that on the death certificate, multiple drugs were listed as causing death, at least 2. So in Southeast, we see that 67% of all of the overdoses are the result of polysubstance use. Oh, I was going to ask you this question. So methamphetamine in Southeast is actually the most commonly involved drug involved in overdoses. This was kind of surprising to me, not because we see methamphetamine, that's really common, but just by how much. So methamphetamine was by far listed on the death certificate more than any other substance here in Southeast, especially or including fentanyl. We don't see the same big increase in fentanyl deaths here in Southeast. It's mostly methamphetamine. Yeah, please.
I'm just curious about that because so if there are multiple drugs listed, why do they choose that to eat the drug that she overdosed on?
Yeah, that's a great question. So probably at least 60% of the methamphetamine deaths also had at least one other substance that was listed on the death certificate, just the way I count it. So I count each drug individually, and then you would see that I think for this time period, there were 25 deaths that involved methamphetamine, even though 20 of those deaths involved other substances.
I see. So it's just that drug is more shared feeling.
Correct. Yeah, great way to say that. Yeah, great way to say that. Yeah. So I just wanted to kind of bring this all back to some implications for prevention. Of course, we talk a lot about opioids, and we should definitely talk about opioids. But I think, seeing this data across the state here in Southeast, it really demonstrates the importance of having some education and bringing some awareness to the danger of using methamphetamine. We don't have a state plan to address methamphetamine or stimulant use in our state, which is a big gap. We'd love to see that move forward. Also, as I mentioned, alcohol plays a big part in drug overdose deaths in Utah as well. And currently, we don't have a lot of funding or research around alcohol, at least at the state level. So I'd love to see, I'd love to see that happen as well.
I see.
You would have passed it back over to Michael.
Good. Okay.
Utah is unique in the fact that we have a centralized medical examiner system. So no matter where a person dies in our state, that death is investigated by one office in Taylorsville, Utah. There are death investigators throughout our state that respond locally to death scenes, but that allows us real-time access to data and also continuity about what kind of toxicology we run, what kind of manner of death, what are the requirements for a death to be a suicide or to be an accident. I'm from Montana originally. There are 56 counties in Montana, which means there are 56 coroners and 56 different definitions of suicide. That doesn't exist in Utah. There's one group of physicians who decide what's a suicide, what's an accident, what's homicide, and so forth. What this also does is allow us to create a program that can reach out to loss survivors, the next of kin, to conduct interviews. Because oftentimes we have enough information to determine the cause and manner of death, but we don't have enough information to determine how to prevent that death. So through these interviews, which usually take place ideally at the 8-month mark after death, kind of like in the 14 to 16 month range right now. We got behind during COVID, but we're catching up. We learn more about how these people lived, not just how they died. And that's ultimately how we're going to end up informing prevention, intervention, and postvention. We call this the Sudden and Unexpected Death Surveillance System, or SUDS. It's not public health unless it has an acronym, so it's how we make ourselves legit. But we attempt to interview a next of kin for every person who dies by suicide or from an accidental drug overdose, or if that death was related to a maternal reason, if the person was pregnant at the time of death or pregnant within a year of their death. They have to be a Utah resident as well. And that actually, because we're on a college campus, I'll say we make exceptions for college students. They might be a resident of Colorado, but they've lived here for 3 years, and we consider them, in our prevention paradigm. So our first aim is to get this circumstantial evidence that helps us better understand how this death can be prevented. But there is a byproduct here, and that was one that I discounted greatly when we started doing this work in 2017 and 2018. And that is this postvention piece, this part about engaging with people who have experienced this tragic loss. And here we are 8, 12, 14, 16 months later, and we find out that that person who died, their bedroom is completely outchanged since the death happened. They didn't clean up the biohazard that remained. They haven't returned to work, but their life is just not going well. And other research tells us that these survivors whose addresses and phone numbers we have are at a significantly higher risk of dying by suicide or even accidental drug overdose than the general population. You've probably seen all the really cool live-on stuff up and down the highways and out on the tables. That's all really cool, but who's that geared toward? That you, the population. But these people, we have the phone number, and we know that they're at least 2.4 times more likely to die by suicide, on up to 22.7 times more likely to die by suicide. You think we should call them? Yeah, I do too. So we did. We've completed over 1,500 interviews related to suicide since October of 2018. Sometimes families are like, I want to talk to you, but I just emotionally can't right now. We still, of course, can we connect you to some people that can help you? And since December 2020, when we onboarded accidental overdose, we've completed roughly 750 of these types of interviews. Parents are the most likely to participate in interviews, followed by spouses. But the majority of these informants, keep in mind, these are the people that are legal next of kin, because we are the medical examiners. So it might not be that cohabiting person that was living with them for 30 years, but they never got married. It could be their parent. But for the most part, we know that the people we're interviewing actually were in frequent contact with the person who died. It's not, uncommon that we get somebody like, I didn't talk to them for 2 years. But for the most part, these are people who knew what was going on.
So we're going to just share a little bit of our findings from our interviews. So we're looking here by employment. So of the people that we asked, people who died by suicide or overdose were more likely than the general population to be unemployed. And of the people that we collected information for, you can see that the proportion was slightly higher for the overdose rate. And then we also, of those people who were not employed, we asked a follow-up question. We asked many follow-up questions, but one of those is if they were looking for employment. This can also include people who are disabled. But of the people who were not employed, most of those decedents were not looking for employment. So here we're looking at homelessness. And one of the things, so recently the state, the Office of Vital Records and Statistics, started collecting information about all people who die on their homelessness status at time of death. So now we have a better understanding of the number of people who were experiencing homelessness at the time of death. So we also asked this question in our interviews, and you can see here that, we don't have the general population here, but people who died by overdose or suicide were much more likely to have experienced homelessness or to be homeless at time of death than the general population. We also ask, it's not included here, but sorry, let me go back here. This is not reflecting just at time of death. We're asking more broadly, have they ever experienced homelessness? And then we ask when. So we know that there is a much higher proportion of people experiencing homelessness at time of death in the general population, but also of people who have ever experienced homelessness.
Religion is a bit of a splintering topic in Utah when we talk about suicide or overdose. But in the research, religion largely points to protection. What is religion? Like work, like friendships? It's social connection for most people. However, religion as a risk factor emerges when people are not accepted in their religious communities, when they feel like they don't belong in those religious communities. This can be LGBTQ people in certain religious communities. It can be people who have experienced criminal history or incarceration. There are a number of different people who might not feel like they belong in their community, whether that be a religion or not, for many different reasons. At the time of death, and we go to the Faith Summit every year, and we're talking to a bunch of clergy folk, both lay and professional clergy. And some of those people are like, yeah, but this is a pie congregation. And we're here to tell you, yes, this is your congregation. 40% of people who died by suicide belonged to a religious congregation at the time that they died. A little over a third of people who died by overdose belonged to a congregation. But we also know that the number of people that did not die from suicide or overdose, the general population of Utah, almost 90% belonged to a religion. We also ask, were they ever religious? And what we see is that more people who die by suicide and overdose disaffiliated from religion over time. That can be a really big life event when your whole family and your community belong to a faith and a certain adherence to a religious practice. And then for whatever reason, that person disaffiliates. We see this in youth and young adults as well, that these big periods of family conflict bring up a great deal of risk. And last Faith Summit, last October, this disaffiliation was part of the theme of that summit. But I think, that, again, we think about people who are leaving their religion for one reason or another. Most people, by the way, according to the Pew Research Foundation, leave religion for what reason? Anybody? Because they just don't want to get up on Sunday morning and go somewhere. It's not some big, profound reason they leave their religion. They just stop going. And especially we saw that during the pandemic. And so, but what happens when you stop going? It's kind of, even though it might be a little more intentional, it is a form of withdrawal. I'm going to talk about overdose first when we talk about service members and veterans, because you actually don't see any big differences between veterans and service members in the proportion who die by suicide, those who are never service members who died by suicide, meaning there's really not a population difference. However, when we talk about suicide, we know that veterans, I know that even the bars don't really show this, veterans are about 3 times more likely in Utah to die by suicide than the general population. Do you think that we should be treating depression among veterans? Yeah, but do you think we should be treating PTSD first? Definitely. So often we say, and I even hear this from medical examiners, they're like, did they have a history of depression? Yes, well then this must have been suicide. Let's back up a little bit and make sure that we're treating the right thing, because we're not going to get the outcome we want unless we accurately diagnose and assess people and treat the problem. And I think that we're seeing that among veterans. One of the key goals is to ask people, did you ever serve? That's the governor's challenge. There's 3 goals and 1 goal. Did you ever serve? Why? Because we know that the VA and the Veterans Administration has way better outcomes when they discover that somebody is thinking about suicide than if they were to go to any other healthcare system. The VA doesn't have this perfect. They've got a pretty darn good system and a way forward.
So there's plenty of research in the literature that supports that pain increases the risk for both suicide and drug overdose. And you can really see that also demonstrated here in our data. So we asked if the decedent had in the last 30 days complained of being in physical pain. And you can see here that almost 60% of the overdose folks said yes, and close to 50% of our suicide decedents had also complained of pain in the last 30 days. Of those, about 50% had reported that they had a prescription for pain. And then on the overdose side, the most common ailment or thing that they were, where they were experiencing the pain was in back pain. Back pain was a very common condition that people were experiencing. We also asked about mental health diagnoses. And I think this one kind of surprised us that there is virtually no difference between these two, between suicide and overdose. So they both, 57% of the respondents indicated that the person who died had a mental health diagnosis. And then the side of the people who did not is also very, very similar. Of those people, we asked you if they had a mental health diagnosis, were they being treated? And actually about 80 to 90% of the people who indicated they did have a mental health diagnosis had received some type of treatment for that diagnosis. You can see the top line here is that the most common was both receiving a prescription drugs to treat the symptoms of that mental health condition and also engaging in some type of talk therapy.
We get a lot more data than what we showed you here today. This was just a little bit of cherry picking of things that we like to talk about, frankly. But we take all of this data and where does it go, especially from these family interviews? And I want to talk about one place where we've seen some really big impacts, at least big in our book, and that's the Suicide Fatality Review Committee. There's also an Overdose Fatality Review Committee, but I want to talk more about this particular committee. So we partnered with University of Utah Health, Intermountain Health, Bear River Health Department as well, and we review deaths in a confidential, mostly de-identified kind of way. We look for gaps and opportunities about where could we have pivoted the story here? Where could we have done something that would have changed the outcome? Suicide and drug overdose are wicked problems. Have you guys ever heard of wicked problems before? This is a research concept, but basically a wicked problem is one that doesn't have one solution. There's not any kind of magic pill out there that will help us fix suicide. Ketamine, I think it, maybe reduces suicide ideation for 2 days, but that doesn't address sometimes the underlying problems. We have to have a lot of solutions to prevent suicide all at the same time. And that's really hard to convince legislators of. You can't just have 988. 988 is one solution that will work for some people.
But confuse them.
So in these suicide fatality reviews, we define the problem. Who is dying by suicide? We also identify risk, the what. And then we develop and test strategies, and then we get people to adopt those strategies, the ones that work. So here are just some results from our Suicide Fatality Review Committee, and this is from the 2 committees that have been meeting for quite some time. They have, through these recommendations from the committee, expanded safety planning in diverse healthcare settings. It's really hard to convince dermatologists that they need to do behavioral health safety plans until you show them the evidence. And you say, this wasn't evidence from Brigham and Women's Hospital in Boston. This was from your facility right here. And they said, oh, all right, well, we're going to learn how to do safety plans. And a lot of these folks have come on board and started doing that. Zero suicide means everybody from the custodian to the CEO have to know how to write a suicide plan, or at least sit with somebody who's going through a rough period of time or a suicidal crisis. We've, through these recommendations, expanded counseling on access to lethal means. I talked briefly about that earlier. You can find that training for free and get a CE online. It takes an hour. Go to train.utah.gov or to Intermountain Healthcare column, and you'll find it. But if you know a healthcare provider who is not willing to talk about firearms or just simply doesn't know how, engage them in a conversation and tell them that this work does save lives. We've also changed suicide risk assessments. How many of you have heard of PHQ-9? PHQ-9 has been deployed widely in a lot of healthcare systems in Utah and throughout the U.S. Is it a suicide screener? Not really. Question 9 asks about suicide, but it's not really a suicide screener. It's a depression screener. Do you know who developed it? Pfizer, when they were trying to sell fluoxetine. That's not to say that PHQ-9 is not good. It is. It's been tested and validated, but it's for measuring depression, not suicide. CSSRS, a lot of people can fill out the CSSRS, score low on risk, and still be suicidal. We have to think about this cumulative risk profile of people. You know what? You don't have a mental health diagnosis, but you are going through a relationship ending. Your finances are in turmoil, and you don't know if you're going to have a job tomorrow. Do you think this person is at risk? Yes. Are they going to score low on the CSSRS? Probably. We have to take the whole person into account, and we focus really specifically in healthcare settings on 2 different kinds of factors: chronic pain and sleep disturbances, and particularly people with chronic pain. Maybe they've had pain for 15 years, and then all of a sudden their sleep starts to deteriorate. What happens to you when you don't sleep? I become a royal monster. I'm Megan's supervisor. She knows. So the last thing is promoting the implementation of universal screening in every ED in a large healthcare system that rhymes with Schminter Mountains. I couldn't, but I'm next to their brain. But they're this summer going to start screening in every ED encounter for suicide. Universal screening is pretty controversial. Because what happens if you screen and somebody says yes? You can't do nothing. And so we have to make sure that if you're going to screen, you've got somewhere to send those folks. And this is going to be a challenge for our rural healthcare providers. But with this crisis system that's been expanding year after year after year, more MCOTs throughout the state, I think we've got a path forward in ways that 5 years ago we couldn't see. I'm really excited about that, about this implementation of universal screening. And so we have about 10 minutes for questions. And thank you for listening to us.
You guys just talked a little bit about creation. I wasn't aware that creation could cause those stones. Oh, isn't it like a gold to kissing a trip with that?
Yeah, that's a great question. So she had said that she was asking specifically about kratom and didn't realize that it could be a substance that someone could overdose on, and asked if it's legal here in Utah. It is. It's not approved by the FDA, but it is legal here. It's considered a supplement here in Utah and other places around the country. It has both opioid and stimulant-like effects. Kind of depends on the amount you use and, of course, just individual factors. There are also a lot of studies that are underway to better understand its medicinal purposes as well. There is some evidence that supports that it could be helpful in helping people withdrawal. And so there's, needs to be more evidence. And so there's a lot of research going into that. Though it is, you can overdose on it, and we have seen that in our office. Most of the overdoses that involve kratom also involve another substance. So very likely the way that it's listed is that those in combination killed that person or they caused their death. Yes, please.
I'm an investigation. So we often see the stuff in the songs.
Yeah.
But we often see burger. We don't do with an overdose where things beat in dark hands and play these shows. We don't have anything. We don't have any resources to get one. And we don't have any resources to give family members who don't come second good. Is that being adjustable?
Yeah, that's a great question. So her question is, she said advanced EMT, and of course it goes to situations where somebody has overdosed, and are these fatal or not fatal or both?
No. So we, I mean, we speak, and we go to suicide tracks where they refuse services, or we check, if we take them to the hospital, that's good. The hospital deals with it. But we go to their camps and they'll offer services. If we had a resource that we refer them to, or a statewide system to refer them to, that would be amazing. But that's not. The hospital has them think. But there's a lot of people that are calling to the gaps because we don't have anything to get.
Got it. So essentially there's lack of resources. They're unable to provide resources to folks when they're at a scene where somebody had overdosed or maybe even attempted suicide or died by suicide.
Yeah, and like I said, the families, we have to deal with anyone. The statistics are very much a family member will be the section.
Yeah, absolutely. You're right. They're at much higher risk for, dying by suicide or even overdosing. So I'd love to speak more with you about this afterwards, but I can tell you, as far as overdose goes, we're just starting a pilot program in Southwest Health District because we received from some funds to do a few projects. And one of those is that we're trying to, the plan is to distribute naloxone and other types of grief and just kind of general resources to folks after there's been a fatal overdose. So when our death scene investigators go to the scene, they'll leave a packet. There'll be naloxone, and there will also be those resources that you're speaking of. And it also can kind of just help with navigating the next steps of what to do after someone dies. We'd love to expand that to this entire state. We really need to prove the effectiveness of this, of course, during this pilot project. So again, I'd love to connect with you, tell you more about that, and see if we can receive some funding to start doing things like that here. You know, if Michael has anything to add about the response time suicide, I'll decide.
Yeah, I think the piece that you added there is that they're saying that they don't want help. You've reversed the overdose. They've, attempted suicide, but it's clear that they're going to live. This is controversial in both of our respective worlds, but the pink sheet is a tool in the tool belt for people who are genuinely unsafe. There's definitely a line of thought and philosophy in suicide prevention and overdose prevention that, if you do something without somebody's consent, you actually could be harming them. And that's very valid. They have to want to get better. And I can't tell you how many times I've had conversations with friends and family where they come to me and they say, my person that I care for is really in a bad place. They're spiraling out of control. And we took them to the hospital, and the hospital said there's nothing they can do. And the only answer I have, which sucks royally, is they have to get worse before there can be an intervention to do something to make things better. This is, as you say, a gap in our system. I would say, even though this isn't happening in every situation, we need to lean on our police chaplains, victims advocates, and build that system out to include social workers who know how to engage in persuasive kinds of interviewing to say, this isn't maybe what you think it's going to be, or will you at least try it and I'll go with you? So that it's not, hey, here's some resources. Can you take yourself to a hospital or to a treatment center that's going to land you into $80,000 of medical debt? Still the cost associated with all these things, but I guess what I just said is there are multiple layers of this onion that we have to solve for folks because we need to know why they're saying no.
We have time for one more question, so you get to close this out.
So I just want to know if you noticed why Southeastern might even so far above for us to see it overdoses, spin some trends.
Yeah, that's a really good question. So he asked if we have any ideas as to why Southeast has higher rates of overdose than the rest of the state. I actually don't know for sure, and so maybe I could, lean on the expertise of someone in this room. But, we speculate that a lot of it started due to opioid prescriptions and having a higher rate of opioid prescriptions. So at one point, Carbon County had the highest rate of opioid prescription suspension in the entire country. I know there's been a tremendous amount of work to lower that, but my gut tells me that is a significant reason why we saw that, people are getting injured, they're getting a prescription opioid, and then, of course, become dependent on that. So I think that's a huge part of it. And then and it's a little bit more unclear about kind of the shift to methamphetamine and why we're seeing, higher rates of that. But if anybody else has any thoughts or ideas on that, I'd love to hear it.
So having worked here for a long time, right? And this is what we all are here to talk about and work on together. I'm sure each of us in this room probably has an idea because it's such a multifaceted, complex issue of why is this happening? But we have high rates of chronic pain here because we have high manual labor jobs. We have very long transportation routes to get anywhere. Our counties are very large. We, for a long time, did not have a lot of services for people in mental health, substance use treatment. However, there is a lot happening in our communities in Carbon and Emory counties and Grand County. So if you don't have one of these books, we have them. I'd be happy to send them out with your EMS groups too. You could hand them to people. I know it's not right, here's a book. But we have a lot of services. Four Corners has a crisis receiving center open 24/7. We have a detox service at Castleview Hospital. We have many, many providers in our community that are working on this and trying to help people because it is such a multifaceted, complex issue. So those are just like a few of the many, many things, right? Intergenerational poverty, intergenerational substance use disorder. So a lot of this is all mixed and mingled. And I think these interviews to understand people more can really shine a light on what's happening. So that's just like a brief answer. But I just want to say thank you again for presenting. Sorry to did you want to add anything after? Okay. Thank you so much for coming down and sharing this information with us. It's really amazing to see. And thank you. Yeah. Okay, I'm going to give people just a couple minutes to stretch your legs, do a bio break if you need one. We're going to set up a sound bath.